Good evening, everyone. I'm Dr. Abhijit Trailokya, heading the medical department of Alchem Laboratories. Welcome you for today's discussion on time to take the lead, practical utilization of SGLT2 inhibitor. So this program is brought to you by Alchem Laboratories and then Alchem Metabolic Division. And this program we are doing since almost more than 1.5 years under the banner of DAPANORM CONCLAVE. So for today's discussion, we have Professor Javed Butler with us. And then to moderate the entire session, we have Dr. Siddiqui from India, and we have national faculty like Dr. Shailesh Lodha, Dr. Naushad, and then Dr. Nirav Kumar. So without wasting much of your time, let me take you through the agenda. It's not moving. What's stuck? Yes. So let me take you through the agenda. So we'll start with opening remarks and introduction to the panelists. Then Dr. Siddiqui will talk about context setting and SGLT2 usage in India. Then Dr. Javed Butler will take us through time to take the lead, practical utilization of SGLT2 inhibitor. We will do panel discussion with Dr. Naushad, Dr. Shailesh Lodha, and Dr. Nirav Kumar. And we'll end the session by closing remark and vote of thanks. So let me take an opportunity and introduce Dr. Professor Javed Butler. He's the president of Beller, Scott, and White Research Institute, professor of medicine at the University of Mississippi, board certified in cardiovascular medicine and advanced heart failure and transplant medicine. He serve on several national committees like American College of Cardiology, American Heart Association, National Institute of Health, and Heart Failure Society of America. He's the president of he's a recipient of Simpson Dake Award by American College of Cardiology as well as a Time Feeling and Focus Award by the American Heart Association. Dr. Butler has authored more than 875 peer-reviewed publications. He served on the editorial board of several peer-reviewed cardiovascular journal, and he has been cited numerous times in America's best doctor list. So welcome, Professor Javed Butler, for today's program. We have Dr. Siddiqui with us, and he is going to moderate the session. He's a director of Rajiv Gandhi Center for Diabetes and Endocrinology, Jain Medical College and Hospital, AMU, Aligarh. Reviewer of various renowned journals like International Journal of Diabetes in Developing Countries, then Indian Journal of Clinical Medicine, that is JAPI, Journal of Nutrition, Metabolism, and Health Sciences. More than 40 articles have been published, almost 15 papers presented in national and international conference, DSI Award, Annual Conference of Endocrinology Society, ACCON, and Osler Award for the year 2010. So welcome, sir, for this program. We have Dr. Naushad with us. He's a senior consultant interventional cardiologist and head of the department. And state conference, published many articles, participated in Athena study in 2005-2007, co-investigator with Dr. Ravi Kishore Narayan Rudralaya, Bangalore. The part of ongoing study with Dr. Cherian in incidence of coronary thrombus in Indian patients presenting with acute coronary syndrome. So welcome, Dr. Naushad, for this webinar. And Dr. Shailesh Lodha is with us, a senior consultant and in charge, Department of Diabetes and Endocrine Society, Jaipur. Presented many papers in national and international conference, Review of Diabetic Medicine, Indian Journal of Endocrinology, Indian Journal of Endocrinology and Metabolism, a principal investigator in many national and international clinical trials on many drugs for diabetes and dyslipidemia. Awarded Jaipur Samaro by government for the work in public education in the field of diabetes and endocrinology. Invited by Ministry of Health, Government of India for preparing guidelines for the doctors on endocrine problem in 2021. So welcome Dr. Shailesh Lodha, and we have Dr. Neerav Kumar with us, a consultant interventional cardiologist and additional professor, Department of Cardiology, IGIMA Patna. Dr. Neerav Kumar is an interventional cardiologist attached to Indira Gandhi Institute of Medical Sciences, Patna, fellowship in interventional cardiologist, Escort Heart Institute, New Delhi, India, first prize at Cardiology Society of India conference for work on fractional flow reserve in 2010, and published many papers in national and international conference. So welcome, sir, for this program. And with this, now I hand over session to our moderator, Dr. Siddiqui. Thank you.
Am I audible?
Yes, sir.
So today we'll be beginning with usage of SGLT2 inhibitors in Indian practice. Now, SGLT2 has become just like a storm. Every physician is using SGLT2 in diabetic patients, irrespective of duration of diabetes, irrespective of complications in diabetes. And to begin with, it started as a drug of choice for lowering blood sugar. Then it came as a drug for increase from blood sugar, took as a effective for cardiovascular disorders, then renal disorders. And in future to come, you will find that it is a drug for disorders in the bone in diabetic patients and a reversal in epigenetics. In our department, we are finding out what are the epigenetic variations in diabetic patients and can it be reverted with SGLT2 inhibitors. So gradually the spectrum of SGLT2 inhibitors is increasing day by day, and it has become such a wonder drug that the moment it is started, the blood sugar level comes near normal as early as possible, including adding to other drugs or just starting this drug as a sole. So the usage of SGLT2, I can assure every physician from Kashmir to Kanyakumari are using SGLT2 as first or second line of drug nowadays. So just omnious octet regarding the factors which leads to diabetes mellitus. One is when blood sugar, diabetes, pancreas are destroyed up to 80%, you get hyperglycemia. Incretin effect in the form of GLP and other DPP-4 inhibitors usage have reduced the hyperglycemia by the incretin effect. Then increased lipolysis in the form of increased fatty acids and hyperglycemia. The glucose is reabsorbed in the patients, which leads to hyperglycemia. The decreased uptake of glucose from the muscle cell further leads to hyperglycemia. Vein is other part which leads to hyperglycemia. And finally, the increased hepatic glucose production by the liver leads to hyperglycemia and increased glucagon secretion by the alpha cells of pancreas. All these factors accumulate to give rise to hyperglycemia. So we are fighting for hyperglycemia, and many drugs have come much earlier, but the effect USA FDA guidelines to ascertain CV safety of from 2008 to 2020, and it has been found that core major effect is the cardiac event, which should be analyzed. High risk population to be included in the programs, and long-term data was required for more than 2 years. So these were the targets which were to be attained. Large number of cardiovascular outcome trials were assessed from 2013. The continuously large number of trials are being going on. Starting from 13 till 22, we have encountered large number of trials. Starting for SEVER trial, Examine trial, EMPA-REC trial, all these trials have leaders trial gradually started coming, and we have started from hyperglycemia to be controlled. Then it came down to the control of cardiovascular disorders along with the same drug. Then finally we came to the kidney and started finding out that it has very good role in patients with diabetic nephropathy. And we found that all the three, hyperglycemia, cardiovascular events, and nephropathy, are taken control by the single drug, that is SGLT2 inhibitors. So, what is the potential protective mechanism of action of SGLT2 inhibitors? SGLT2 inhibitors decreases glucose and sodium by the SGLT2. SGLT2 channels are present in the GIT tract as well as in the kidneys. They carry the glucose, along with them they carry the sodium, and this along with glucose lowers the sodium level, leading to decreased blood pressure. But there are patients with old age who have decreased sodium, hyponatremia, syndrome of inappropriate ADS secretion, and nerve conduction velocities are all have slight problems with decreased sodium level from the body. But then this too leads to osmotic diuresis and removal of the sodium from the body. Regarding the link, which helps possible protective effects, leads to decreased BP because sodium and other factors are also being reduced. It decreases arrhythmias. It decreases arterial wall structure improvement, insulin secretion, and oxidative stress, which is the most important cause leading to all the complications of diabetes. Increased glucagon from glucose. It doesn't leads to free glucose to travel into the blood vessels and forms the glucagon. And improves autophagy, which we all know is a new term which has been introduced. It decreases the inflammation and the fibrosis, finally leading to glomerular protection in the form of decreased glomerular pressure, decreased albuminuria, and increased renal oxygenation. This finally leads to cardiovascular and renal outcomes, benefits in the form of decreased cardiovascular deaths, decreased sudden deaths and fatal heart failures, hospitalization, heart failure, and renal illness. So SGLT2 has a very good role in renal as a cardiovascular protection and blood sugar level control. These are the drugs which are in this group, includes canafloxacin, empagliflozin, dapagliflozin, and ramagliflozin. The trial has not approved by the US FDA, DCGI regarding this drug. MACE is the three-part composition of cardiovascular death, non-fatal MI, and non-fatal strokes. It is major adverse cardiovascular events. So canafloxacin first is as an adjuvant to diet and exercise to improve glycemic control in adults with diabetes. Then DCGI and US FDA has approved it to reduce the risk of MACE in patients with diabetes and CVD events. Thirdly, excuse me, the risk of end-stage kidney disease, which doubles the serum creatinine, CVD death, and hospitalizations for heart failure, adults with diabetic nephropathy. Its use has been in this canafloxacin, has been approved by these groups. Regarding EMPA, the first one is the same, and it is used and approved by the DCGI to reduce the risk of CV deaths in adult patients with diabetes and established CVD diseases. DAPA has the same first beneficial effect and it has been proved, and US FDA has proved to it reduces the risk of hospitalization in heart failure in adults, and DCGI has proved that it has a beneficial effect up to chronic stage disease 3 in kidneys. So amongst all these, it has been found that the drug has a better effective role amongst all the SGLT2 inhibitors. Regarding if we group the three major SGLT2 inhibitors now being prescribed all over the world, HbA1c reduction is the maximum is dapagliflozin. Weight reduction, no doubt, is between the two groups of AMPA and CANA, it is minus 2.9. Systolic blood pressure and diastolic pressure are the maximum reduced by the group dapagliflozin. So if we want to choose amongst the three, we can see from the screens that the best outcome amongst all the three groups, amongst all the three SGLT2 inhibitors, it has been found that DAPA has a better outcome amongst all these three. SGLT2, I have already told you, has become the major drug as far as number of patients and the amount of rupees which have been input as for the patients taking SGLT2. Look at the number of patients from 35 lakhs, it has increased to 107 lakhs patients have been put on SGLT2, and the year has not yet ended. And the value it has costed is 1594 crores, which has been used. So I think the amount of value is not as significant as the number of patients which are being prescribed and treated and have been better taken care of. As far as glycemic control, which has been already there, which I think you all might have gone through this chart, it is 2020 chart, that the use of GLP-1 and SGLT2 has surpassed the sulfonylureas and other drugs which we used to prescribe to begin with. They have, along with metformin, if the HbA1c is less than 7.5, we used to start all these medications. But now, on every treatment card, you will see SGLT2 inhibitor as the first line of medication, along with metformin. The drug has surpassed all the other. Then, if the HbA1c is more than 7.5 and reaching up to 9, again, in the lead is SGLT2 and GLP-1 analogs. Look at this, and it has far behind left all these drugs which we used to take earlier. So we begin with these two drugs. Suppose after 3 months of therapy, dual therapy or triple therapy, we don't get any response and our HbA1c is more than 9, then we switch over to triple drug therapy, adding insulin to it, and or we completely shift over the patients to insulin along with GLP analogs, which we have found a very good results, adding insulin along with SGLT2 inhibitors. So other 2022 ADA standard for medical care, the things which have included is atherosclerotic cardiovascular events, indicator of high risk heart failure or CKD, chronic kidney disease. So SGLT2 has shown us a very good results in heart failure patients. Chronic kidney disorders, it reduces the albuminuria. Finally, in high risk also patients with kidney and cardiovascular disorders, it has been found SGLT2 have shown a very good results. From this chart, we can see that the therapy with comorbidity conditions, the drug SGLT2 inhibitor has surpassed many drugs which were previously being prescribed as the drug of choice. Then, from hyperglycemia, Cardiologist Society guidelines has started that SGLT2 with patients with diabetes and cardiovascular disorders, they had started including SGLT2 and GLP-1 receptor analogs for primary prevention of cardiovascular disorders in patients with already on metformin to prevent the cardiovascular risk factors. And European Society guidelines again say that in pre-diabetics and cardiovascular disorders, it will be much beneficial to start SGLT2 inhibitors along with metformin or as a plain drug for patients with pre-diabetic. Then in 1992, European Society have recommended the use of SGLT2 associated with lower risk of heart failure. Hospitalizations in patients with diabetes were recommended. And first line of treatment along with metformin, SGLT2 was included. And they had shown that heart failure, clinical features, biochemical parameters have all contributed in near reversal of the features by adding SGLT2 inhibitors. See, from at risk of heart failure to pre-risk heart failure to heart failure with refractory reduced ejection fraction, with minimal ejection fraction reduction, with normal or ejection fraction. So all have been well taken care by the use of SGLT2 from at risk to high risk patients with low ejection fraction, all have a role in being prevented by SGLT2. So cardiologists and endocrinologists both are prescribing the same medicine and getting very good results in diabetic patients which are even at risk of diabetic failure. Treatment with CKD, I have told you, cardiovascular events. Regarding chronic kidney disease, we generally stop metformin if the eGFR is less than 30. And SGLT2 also, we generally avoid if GFR is less than 30. We do not initiate this. So, till 30, these two drugs are very effective in the management of patients with nephropathies. Now, where we are in 2021, previous years, these were the 5 preferred for refractory heart failure with reduced ejection fractions. It was 5-pillar theory: AC inhibitors, neprilysin inhibitors, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. They were the pillars, and they are still the pillars for patients with heart failure with reduced ejection fraction. And previously, these were 4 were included. Now SGLT2 has shown us very good results. As a cardiologist, what proportion of patients are eligible? Large contemporary USA registry of patients hospitalized with heart failure suggests 4 of 5 patients with heart failure with reduced ejection fraction would be candidates for initiation of SGLT2 inhibitors. The capture cross-sectional study has shown that 1 out of every 3rd of all the patients with type 2 diabetes have established CVD events. And 2 out of 10 has shown that less than 1 in 4 people are being treated with glucose-lowering drugs with proven cardiovascular benefits. So what are the challenges which we are facing today is make clinical practitioners implement SGLT2 inhibitors, which we have already established. Every physician on their treatment card have started writing SGLT2 inhibitors because all the patients with diabetes are going to have cardiovascular events in future. Regarding the cost effectiveness, the cost has reduced drastically as far as SGLT2 inhibitors. So it is not a big issue from these 2 factors as far as our country, India, is concerned. We have overcome these problems, both these problems in our country. So I had only told you that in 2014, we started SGLT2 as a diabetic indication. From 19 to 20, it was cardiac indications which were taken along with diabetes indications. In 2021, nephrology has become a major concern, and treatment with SGLT2 has shown a very good result if the patient from diabetic to cardiovascular to nephrology. And maybe in 2024 or 25, bone and other neurological disorders will be taken in epigenetics, and all molecular level targets we may find that SGLT2 has a beneficial effect in the diabetic patients with bone disorders or osteoporosis. It could become a drug. It could become a drug for neuropathy also. We may, and we, in our institution, we are going through all the research scholars. My 4 or 5 PhD scholars are involved in all the epigenetics regarding the patients on SGLT2 inhibitors. We are also taking care, is there any beneficial role of SGLT2 inhibitors on the bone or harmful effect of SGLT2 inhibitors? We are also trying to see, is there beneficial or harmful effect of SGLT2 inhibitors as far as Alzheimer's disease or depression or all those conditions associated with diabetes? Does SGLT2 take care of these features or deteriorates these features? Thank you, everybody. I think the take-home message, as far as my lecture is concerned, that the best drug to begin with, maybe if along with metformin, SGLT2 is supposed to be the best drug for a patient with diabetes, irrespective of the weight of the patient and any other features. Thank you, everybody.
Thank you, sir. So now I request Dr. Javed Butler to start his presentation.
Great. Well, thank you very much. I appreciate the opportunity to talk to you all. So I will follow up with the previous presentation in a fairly seamless manner. My disclosures are at the bottom of the slide. So what I intend to do is basically talk about two things. So to build upon the last presentation, talk a little bit about what the data are today and how it all evolved, and then move on into what the future clinical trials and the data with dapagliflozin is coming out in the near future. And then finally, we'll talk about the real life use of these agents and some of the concerns. But that part of the presentation, I had to pick one disease entity, and being a heart failure cardiologist, I thought I'll give you a heart failure example, but obviously those examples can be extrapolated to any other disease state as well. So first, we used to think about these diseases individually: diabetes, chronic kidney disease, heart failure, but we do realize that there is a significant overlap in these disease states. And the reason why there is an overlap in these disease states is that the underlying milieu, the underlying pathophysiologic milieu that the body has is actually the same for all three diseases. And it turns out that it's not that these are just common diseases that happen to be prevalent in the same patient population, but because you have this, pre-diabetes, insulin resistance, obesity, hypertension, inflammation, oxidative stress, endothelial dysfunction, all of these things are prevalent in many patients, populations out there. And these are the things that put you at high risk for heart failure, at high risk for chronic kidney disease, at high risk for type 2 diabetes. And because they put you at high risk for all of these diseases, it's not unusual to see that they tend to come together. In fact, I would even say that if a person presents to you with one of these three diseases, one can be reasonably certain that the other diseases, if they are not clinically manifest, at least have subclinically started, and things are unfortunately moving in that direction. This also then explains that if you have a therapy like SGLT2 inhibitor that targets one of these pathophysiologic mechanisms, that the potential benefit is then seen across more than one disease state. So as we know, this whole thing with SGLT2 inhibitor was started with the cardiovascular outcomes trial. So again, for the sake of discussion today, I will focus on the data with dapagliflozin, but we know that there are other SGLT2 inhibitors out there as well. So the DECLARE trial was the largest cardiovascular outcomes trial in patients with diabetes. 17,000 patients, about 10,000 patients did not have atherosclerotic cardiovascular disease. 7,000 patients did have. Broad group of patients. And what you found was that there was a substantial reduction in the risk of cardiovascular death and heart failure hospitalization. So the question came up, where is this benefit coming from? Where is the heart failure benefit coming from? Is it all prevention? Is it treatment as well? So then they looked at the specific subgroup of patients, about 15% or so that did have heart failure at baseline, and those patients had substantial benefit. So if you were to do some math, you have a 17,000 patient trial, 85% or so did not have heart failure. So one thing that you proved is that in patients with type 2 diabetes, you prevent new onset heart failure. The bigger question, however, is what is seen in this slide, that those patients that did have heart failure, there were substantial benefits seen. So what is the mechanism of action? Now, mechanism of action is a full 1-hour discussion in itself. The bottom line is that these drugs have beneficial effect on the heart, kidney, systolic function, diastolic function, vascular function, endothelial function, mitochondrial function. So there's a lot of benefit, and they reduce inflammation and oxidative stress. So then the next question came up, if a drug can do all of these things, then perhaps what we have is a cardiovascular risk modifying agent, irrespective of diabetes. So sure, they are a great anti-diabetic drug and should be used for diabetes. But when we start going into cardiovascular diseases, then maybe we should treat irrespective whether somebody has diabetes or not. So that led to the trials in cardiovascular diseases. The first trial with DAPA that came out was DAPA-HF. That was in heart failure with reduced ejection fraction, about 4,700 patients randomized on top of standard of care to dapagliflozin or placebo. The trial was a huge hit. This is the primary endpoint of cardiovascular death or worsening heart failure events. There was a 21% relative risk reduction, 4.9% absolute risk reduction, and a number needed to treat of only 21. If you look at the two components of the primary endpoint, cardiovascular death or heart failure hospitalization, or if you look at those with and without diabetes, none of that made a difference. So here is the data for diabetes and no diabetes. Of course, patients with diabetes are at a higher risk than those without diabetes, but the relative benefit is seen in both groups. So we truly prove that these drugs are both anti-diabetic agents and cardiovascular risk modifying agents, and that cardiovascular risk modifying agency extends to beyond diabetes as well. And here, heart failure hospitalizations and worsening heart failure events were substantially reduced, and there was a significant reduction in cardiovascular mortality as well. There was significant improvement in quality of life and patient symptoms as assessed by Kansas City Cardiomyopathy Questionnaire. The therapy worked across the patient age group, whether you're younger or older. Sometimes older patients are not treated as aggressively, but the benefit was seen all across. And the benefit was seen all across the range of ejection fraction that was studied as well. And then finally, the baseline medical therapy did not make any difference, whether you are on an ARNI or not, whether you are or not on an MRA, doesn't matter. All subgroups of patients had substantial benefit. So no matter how you slice and dice this trial, the results were substantially positive. So after DAPA-HF came DAPA-CKD, which was the chronic kidney disease trial. So this was the first trial in the kidney space that assessed an SGLT2 inhibitor in patients with and without diabetes. So the entry criteria was eGFR between 25 and 75 with a UACR of at least 200 plus. These patients were randomized to dapagliflozin and placebo and were followed. So the primary endpoint was a composite of cardiovascular and renal endpoint. So sustained reduction in eGFR of greater than 50%, end-stage kidney disease, renal replacement therapy, dialysis, renal transplant, or renal or cardiovascular death. So this was a composite endpoint. And as you can see, significant improvement. There was a 39% relative risk reduction, number needed to treat of only 19, with substantial improvement with the addition of dapagliflozin. Again, very much like DAPA-HF, diabetes or no diabetes at baseline made no difference. And stage 4 versus stage 2 and 3 CKD, so those patients with more advanced CKD versus less advanced CKD, all of them benefited both from renal and all-cause mortality benefit as well. So this now extends this drug with positive trials and type 2 diabetes for glycemic control, for heart failure prevention, then HFrEF, heart failure with reduced ejection fraction treatment, and then DAPA-CKD with chronic kidney disease, and HFrEF and CKD irrespective of diabetes. This was the benefit in the renal function and the preservation of EGFR. Remember, the vast majority of these patients were already on RAS inhibitors, and despite of that, there was a linear drop, which was reduced with the use of dapagliflozin to the tune of about 2 ml per minute per year in the long run. So then now we are sort of trying to fill in the boxes. So what are the boxes we have filled? Well, we have filled type 2 diabetes, we have filled HFrEF, irrespective of diabetes, we have filled CKD. Now the question is, what about the rest of the heart failure? So what is the rest of the heart failure? Well, you have HFpEF, and you have acute heart failure, or the patients with hospitalized heart failure. So the Hefpef trial just announced literally like 3 weeks ago, 2 weeks ago, the top line result that the trial is positive. It was a 6,000 patients study in patients with heart failure, preserved ejection fraction. That will be presented later that year. So I don't know of any of the results, that they have not been declared, except that the company did have a press release that the primary endpoint was met in a statistically significant and a clinically relevant manner. So now we have another checkbox: HFrEF, HFpEF, CKD. What about acute heart failure? So again, a large study, 2,400 patients being followed longitudinally to see what happens when you start the drug in the hospital setting. The results of these trials are pending. I don't know any, that there have been no press releases per se. So then the last group of patients which is left is post-MI patient. Can you prevent in an acute setting by giving an SGLT2 inhibitor future risk for cardiovascular death or new onset heart failure? That trial is also ongoing, over 6,000 patients, DAPA-MI, and that trial is ongoing. So if you and I were to talk again in say a year and a half, we would have checked all boxes: HFrEF, HFpEF, acute heart failure, post-MI, and CKD, but we are heading in that direction, but we are not there quite yet. So now let me switch around a little bit, and this was just the background of the robustness of the data that has already been available and will be coming out, to more about practical management of these patients. Now, when some of the drugs that came out in the past, so I will now shift the discussion a little bit towards heart failure, literally just as an example. I mean, I can put the diabetes guidelines and probably say the same things that I'm going to say. So, you know, some of the drugs, when they came out, they required a lot of physician education because you have to manage the pharmacodynamic profile and the side effect profile. So for instance, you know, if you give beta blockers in heart failure, you need to make sure what happens to the heart rate, to atrial fibrillation, to congestion. If you give MRAs, you have to teach the physicians, you know, how to use MRA, when to not use, what are the contraindications, what do you do if somebody's starting potassium is 4.2 versus 5.2, what do you do if somebody's starting creatinine clearance is 60 versus 35, so right, there's a lot. When it comes to SGLT2 inhibitor, I mean, it's just simple. It's basically just one pill and you just give it, and there's not a lot of sort of things that you need to worry about. So what the guidelines are now doing in heart failure, because there is a perception that we have about four foundational therapy that has been shown to improve outcomes. But what is fundamentally being changed, so this is the algorithm and we'll only focus on the top from the European Society of Cardiology, saying that the standard of care for patients with HFrEF is RAS inhibitor, beta blocker, MRA, and SGLT2 inhibitor. And by the way, I am pretty certain that chronic kidney disease field is moving in that direction, not there quite yet, but combination therapy will become the standard of care. But here, what we are seeing is that these are the four therapies which are foundational. But what is the big difference is that the previous guidelines tended to be very prescriptive. They told you where you need to go and how to get there. You start this medication first, wait for this long, start that medication next, wait for this, up titrate the dose. All of that is gone. Now the guidelines are basically telling you where you need to go, but leave it to you how you get there. And the reason for that is that none of our patients are the same. So how can we apply the same algorithm, right? And also, sequencing is a historical construct, not a biologic construct. Is a history of medicine that we tested ACE inhibitors in the 1980s and beta blockers in 90s and ARNIs and MRAs and SGLT2 inhibitor. It's just history how things evolve. But there's no reason to believe that you have to give one medication before the other before you might see the benefit of the other medication. In fact, we have data showing exactly the opposite. So I will go over that. But bottom line is that on the basis of EMPEROR-reduced and DAPA-HF results, now the European guidelines for HFrEF are recommending that it should be a foundational therapy that should be given to all the patients. When the European guidelines were written, the data with EMPEROR Preserved was not out yet, so it was only in HFrEF. But then the American guidelines came out, and by that time, the EMPEROR Preserved trials were known, results were known as well. So here you see across the spectrum that SGLT2 inhibitors are recommended. Stage A, heart failure, your hypertensive diabetic patients to prevent heart failure. Stage B, patients with diabetes, structural heart disease, atrial fibrillation, left ventricular hypertrophy, raised NT-proBNP level to prevent heart failure. Stage C, HFrEF, mildly reduced EF 41 to 49, or HFpEF. SGLT2 inhibitors are recommended all along. And very much like the European, there is no sequencing. It is left up to the clinician on how to use these drugs. Now, why is it so important and why is there such a big push to give the combination therapy? And the reason for that is that, unlike, say, cancer chemotherapy, where you improves the survival by a few months, here, if you give the combination of these four therapies, we are talking about a relative risk reduction of almost 75% and an absolute risk reduction of 25% for a number needed to treat of only 4. So this will only happen if we actually prescribe the data to the patient. So how are we doing? I can literally show the data for diabetes, for post-MI patients, for heart failure patients, for CKD patients. The bottom line is that these drugs are not being used despite of the fact that global regulatory agencies and global professional society guidelines are all recommending the same thing. So there is no controversy about the use of these drugs, but for various reasons, we don't use. So the number one thing that people say that they're not using it is cost. So let's think about that a little bit. So these are the data from the CHAMP registry. This was a heart failure registry in US, about 5,000 patients. We did this cut when we had about 500 patients. The reason why I do this is because when we designed this registry, we upfront took care of a few things. This registry, by the way, was up to about 2018. So this is just shy when the SGLT2 inhibitor data came out. But nevertheless, there are some really important learnings. So if you look at the registry data, the criticism that people have is that when people are not on therapy, it's maybe because there is no documentation in the medical record of intolerance, but maybe they don't tolerate. That's one. The second criticism they do is that people are not on therapy because maybe you just collected the data at the wrong time and the doses were just being up titrated. And if you had follow-up data, you would see the benefit. That's the second thing. And then the third thing is, again, the issue of cost, which again, cost is definitely an issue. I don't want to minimize the importance of cost. But again, that's given as a big reason for why therapies are not given. So the reason why I like showing these data is that we try to take care of these issues in this registry. First, we did not collect just the data from medical record, but we actually asked the clinicians that we will give you credit for any known intolerance. Forget about contraindication. If a physician said that mild dizziness and I don't want to give, mild whatever we don't want to give, we were said, fine, just let us know so that we have a pure denominator. Then we collected the data longitudinally as well. And remember, this is a select group of sites that knew that we were monitoring their heart failure therapy, and they were interested in heart failure enough to participate. And despite of that, triple therapy, this is pre-SGLT2 inhibitor, just triple therapy with RAS inhibitor, beta blocker, and MRA was seen in less than 25% of the patient. And remember that ACE inhibitor, beta blocker, and MRA, when this study was done, were all generic. This does not need to include ARNI or SGLT2 or Vericiguat or any of the expensive medicine. All generic medicine, all contraindications, all intolerances taken out, and yet 75% of the patients were not on triple therapy, and the appropriate doses of triple therapy was seen in less than 10% of the patients. So huge amounts of gap. And then this issue that maybe you just looked at the data at the wrong time, and that if you had longitudinal data, you would see, and the bottom line is, it is what it is. The patients, the doses, the small doses that were given were never changed over time. So there's a lot of inertia. Another reason that people say is that, well, patients with low blood pressure don't tolerate it. So we excluded those patients with systolic blood pressure less than 110 and only focused on those with systolic blood pressure greater than 110. And again, the use was consistently low even in those patients. Now, is it something impossible to do? And the answer is no, because if you look at the spread across different sites, there were sites where triple therapy was given to less than 10% of the patients, eligible patients, and there were other sites where it was given to more than 70% of the patients. So basically, if you wanted to do it, there are obviously ways to get it done, but medical inertia plays a huge role. So coming back to this old prescription of very strict sequencing, going, do this first, do that second, and now moving on to just flat and leaving it to the clinician, that all we are telling you is to give these therapies, SGLT2, beta blocker, MRA, and RAS inhibitor. We are not going to tell you how. Why did that change occur? It is actually now even recommended that if somebody is in the hospital, start all of these medications in the hospital before the patient goes home. So why did this change occur? Well, one is that the sequencing emphasis, as I mentioned, is completely gone. There is no fixed sequencing, just use whatever sequencing you want, because as I said, sequencing is a historical construct, not a biologic construct. The second thing is that it is more important to have all the relevant drugs on board before you up-titrate the dose. Because what ends up happening is that if you give maximum doses of ACE inhibitors, then maybe your potassium is high, maybe your creatinine is high, maybe your blood pressure is low, and then you don't give other medication. It is better to give low doses of everything so that all relevant pathways are covered before you up-titrate the dose, which doesn't mean don't up-titrate the dose, but first cover all the pathways. And then the last emphasis is that the sooner we do it, the better, because these drugs benefit relatively very soon. So why move away from sequencing, even if it is a historical construct? So what? Why don't we just follow the history? And the reason for that is that it takes a long time. If you go step by step by step, in a best case scenario, the patients are seen every 3-4 months. Even if you do a little bit sooner, it takes months and years. and inertia sets in. And that's one of the big reasons why patients get dropped off. They start maybe feeling a little bit better. The clinicians are busy and those treatments are not given and the patients are put at high risk. The other reason why sequencing is de-emphasized, as I already mentioned, not all the patients are the same. So you got to match the treatment to the patient, but also the baseline therapy doesn't matter how you start. So for instance, Ralph's trial that had MRA given, only 10% of the patients were on beta blockers. So this was an early era of heart failure. By the time Emphasis trial was done, beta blockers were standard of care. 90% of the patients were on beta blockers. But doesn't matter whether you were on beta blocker or not, both groups of patients with MRA benefited. In other words, you don't need any specific background therapy. Same thing with SGLT2 inhibitor. Whether you're on an ACE inhibitor or an ARNI, doesn't matter, you get the benefit. We saw the same with ARNI, whether you're on an MRA or not. And the reason for urgency is this. With all of these therapies, the benefits are seen within a matter of weeks, less than a month. In DAPA-HF, the cardiovascular death, heart failure hospitalization became statistically significant within 4 weeks. So these drugs work relatively fast. So when we follow some strict sequence for which we have no good rationale, which doesn't fit all the patients, and we take months on end, not only do we end up not giving the appropriate therapy, but during that time, we are putting patients at high risk as well. So this is something that we sort of try to argue, that we realize that inpatient setting is different than outpatient setting. But the issue here is not inpatient and outpatient as much as it's psychological. If you think about it, when patients come in with myocardial infarction, in 2, 3, 4 days, we start 5 or 6 new classes of medications. But when it comes to heart failure, why does it take months and years? So we just, again, made the same argument here: televisit, telephone, just short visit with the nurses, something or the other in 4, 5, 6 weeks. Let's just get the appropriate medications on board before you worry about the dose. Now, dose is not an issue with dapagliflozin or SGLT2 inhibitor. It's just one dose and you're done. Sort of is not an issue with MRA. 25 milligrams is good enough. There are really no dose ranging studies. It's mainly an issue with ACE inhibitor, ARNI, or beta blocker. But again, first let's cover all the doses. And again, some of the benefits that are seen, and these benefits are seen relatively very early, and it is safe and well tolerated. In fact, the red line here is not heart failure patients not getting anything. This is heart failure patients already getting an ACE inhibitor and beta blocker. And if you switch ACE inhibitor, beta blocker to dual therapy to quadruple therapy, you're improving survival in excess of 6 years. 6 years. So the benefits are very, very substantial. Now, so how do you use these multiple drugs when all the patients come in all different forms and you are not prescribing any sequencing? So the European Society of Cardiology came up with these different phenotypes based on CKD, heart rate, congestion, blood pressure, atrial fibrillation, all of those things to make some sort of rational decision of which drug should be started first. Remember that some drugs also facilitate other drugs. So for instance, if you have a heart failure patient who's congested, they may not tolerate beta blocker, but if you give beta blocker in conjunction with an SGLT2 inhibitor, and because SGLT2 inhibitor will make you diurese some, you will tolerate beta blocker better. If somebody's potassium is on the higher side, they may not tolerate MRA, but SGLT2 inhibitors actually lower the risk of hyperkalemia, so that may be tolerated. But what was impressive in this diagram is that no matter what your phenotype is, based on multiple physiologic parameter combination, SGLT2 inhibitor could be given to all of these patients as a first-line therapy without any problem. Now, when you do patient surveys and try to find out what exactly are our patients looking for, what do they want? Well, it turns out that they want to be they don't only want to live longer, but they want to live independently. they don't want to come to a hospital. They don't want to go to emergency room. They don't want to go to rehab facility. They don't want to go to nursing home. They don't want to go and live with some family member because they cannot live alone. So those are the things that the patients are wanting. But if you look at a typical heart failure patients after discharge, about 80% of the patients come right back in to some other facility or another. So how can we give the patients what they want? Well, you need to give them the drugs that improve the outcome. But in this survey, before the SGLT2 inhibitors became the standard of care, patients had no idea about drugs like MRAs or ARNIs that can improve outcomes. I would think SGLT2 inhibitor is even lower. And they had a very misperception of the safety concerns. Now, I don't want to leave this talk by saying that safety is not important. Of course, safety is very important, but they have an exaggerated concern about safety and an undervaluation of the benefit so that the net looks worse. So in that sense, talking to our patients and educating the patients become really important. So I will end my presentation by saying that if I were to go on a blackboard or a whiteboard and just theoretically say, what is an ideal drug for heart failure? What is an ideal drug for CKD? What will be an ideal drug characterization will be? Well, here it is, that it's one pill, once a day, one dose with no dose titration, that it improves clinical outcomes, that it improves quality of life outcomes, that the benefits are seen early, rapidly after giving, that it is safe and well tolerated, that other reasons for which other therapies are not tolerated, like heart rate, blood pressure, potassium, creatinine, none of those are issues. And oh, by the way, while you're giving it for one particular disease entity, you have these side benefits for other diseases. So you get benefit for heart failure prevention, heart failure treatment, CKD, metabolism, new onset diabetes, insulin needs, all of those things occur, weight loss. That drug would be an SGLT2 inhibitor. So I will end by saying that, we all say that heart failure has as bad a prognosis as a cancer, and it has been shown over and over again. But just think about how a cancer doctor thinks, right? The cancer doctor says, well, you have a life-threatening disease. I will give you a combination of this therapy that has the best chance of improving your outcomes. I know that the therapy will have a lot of side effects, but we will work with you to mitigate the side effects. What happens in heart failure patients? Any simple intolerance, dizziness, whatever, potassium of 5, we just put brakes. We say, well, let's give some therapy, see how the person does before optimizing therapy, and we'll optimize therapy when things get worse. This is like a cancer doctor saying that I'll give you half the cancer treatment, and let's see if the cancer gets worse or not before you give everything. That's not the right way. I again want to emphasize, I don't want to say that we should not worry about side effects, but many of the side effects from these drugs are easily manageable. Low blood pressure, well, cut down the dose of diuretics. Don't give all the medications at the same time. Space them out, morning, afternoon, evening. Give low doses of the medication. High potassium level, give low doses. There are novel potassium binders out there as well. Genital myocardic infection, genital hygiene and keeping the area dry and clean, the risk goes down to less than 2%. So there's a lot of things that we can do, but first saving the patient's life becomes very important. So I will stop here. I will be happy to take the question. This was a lot of information, but I appreciate the opportunity to be with you today.
Hello, Dr. Siddiqui. Sir, I think you are muted. Can't hear
Am
me.
I audible?
Yes, sir.
Dr. Javed Butler, I want to communicate to him that his lecture was excellent. Sir, your lecture was excellent, but is there any difference with the seasonal? I have one question. Is there any seasonal variation with the use of SGLT2 inhibitors? Is there any change in the usage from winters to summers because we have drastic change in winters and summers? This is one question. The other question which we wanted to know is that the hygienic conditions and different conditions from other countries is different from developing countries or our Indian subcontinent. So, is there any difference or what should be our priorities because the level of hydration, because the level of hygiene may be different from India to USA to other developed countries. So what is your advice that the hygiene and the seasonal variation, do they affect the usage of SGLT2 inhibitors?
Yeah. So obviously, both of these are really important practical questions. To my knowledge, there are no data to it, but that doesn't mean that the patient is not sitting in front of us, right? So at the end of the day, we are clinicians, so use our best judgment while managing the patient makes a lot of sense. So if there is really hot weather, I mean, I was reading some magazine that in India this year, the summers are expected to have the worst temperature in a long time. So of course, with all the sweating and the insensible losses of the fluid, and then you're giving therapies that have diuretic properties, is intravascular volume depletion a concern? Now, the problem here is that there is no way to come up with a formula of what to do in these situations. But what you could do is, of course, make sure that the patients and give them the recommendations that if they are not on diuretics, say you're giving it for diabetes or some other reason, they're not on diuretic, to just keep very well hydrated to make sure that they don't get dehydrated during the process and take an extra concern. If you already have a patient with heart failure where you're concerned about hydration, then proactively cutting down the dose of diuretic may be warranted in that situation. Cut down the dose by 50% or something. The problem here is that, again, one cannot make it into a formula, right? So some patients, you cut down 50%, they will be fine. And some patients, you cut down 50% and they may start developing swelling again. So again, this has to be individualized with some sort of a close follow-up. Now, in terms of the genital hygiene, first of all, for instance, we'll see what the DELIVER trial shows in Emperor Preserved. The genital myocardic, so there was no increased risk of UTI. It was all genital myocardic infection, and the risk was about 2.2%. So the risk is pretty low to begin with. And in countries that regularly use more genital hygiene and keep the area dry and clean and wash it with water, that risk goes down even further. If you do get an infection, then either topical or oral therapy, you treat it, you don't stop an SGLT2 inhibitor, and the chances of recurrent infections are really low. The place where it really becomes a problem is, if you have a nursing home patient who's, say, on diaper or something like that, and they get recurrent genital myocardic infection, and at that point, you just have to compromise the therapy because they are just not going to tolerate it.
So one more question from you. That is, what is its effectiveness during Ramadan? We have Ramadan here, especially in summers, and we are using this SGLT2. So what is your expert advice?
Yeah, so, I'm a cardiologist. I actually don't have any expert advice, and I would lean to my endocrine colleagues, but there is a little bit of a concern there, because not only in Ramadan, two things happen, right? So one is the fluid issue, but the other is decreased caloric intake and lowering of the insulin dose. And will this put somebody at a higher risk of euglycemic diabetic ketoacidosis or not? And whether during the Ramadan it should be held. I actually don't know, but I would love to learn from any endocrinologist on our panel today.
Thank you, sir.
Sir, should we go for panel discussion? There are a couple of questions which we got from doctors, and basically they wanted to, understand certain issues with SGLT2 inhibitor. So what we will do we will take these questions and then we will discuss. So let me share my slide. We'll start with panel discussion, and then I would like to invite Dr. Naushad for a discussion, and then there are two important questions for Dr. Naushad. So basically, these questions we got from we did survey across all the Indian doctors, and these are the common question what we got from doctors, and they wanted to understand how does SGLT2 inhibitor improve heart failure, and then what is the impact of SGLT2 inhibitor in reduce ejection fraction as well as preserve ejection fraction. So over to you, Dr. Naushad.
Hi, good evening. It was a very nice lucid talk, Dr. Butler. Congratulations. I think it's already answered the question very pertinently. There is as he said, you have to give at least 1 hour to tell us how does it improve the heart failure. The basic mechanism is natriuresis. Because of natriuresis, there is reduced blood pressure, and there are, as we keep saying about the statin, it has got a pleiotropic effect. I think we may have to call the same thing with maybe SGLT2 inhibitors as well, since it has got an effect on the kidney as well as on the heart, endothelial function, and the mitochondria. All these things put together, along with weight reduction and improvement in the glycemic index, all put together, we cannot say it is only one point which is the basic and the root mechanism for the improvement in the heart failure. It is multifactorial, and one of the basic mechanism is sodium loss and natriuresis and osmolality. These they have impact on the heart failure management, and impact on the SGLT2 in both reduced and preserved, and it's very clear. So even though we started with reduced ejection fraction where the EF of around 40% and less than 40% were taken into consideration, and initially it was started with having patients with the diabetes, but we have moved from that where both people with diabetes or without diabetes, and whether it is a reduced ejection fraction or whether it is a preserved ejection fraction, independent of the comorbid conditions and LV ejection fraction, in all the subgroups, SGLT2 have shown the clinical benefit, as the talks was very clear about that. And all the studies also are very clear about it.
Thank you, Dr. Naushad. Maybe Dr. Butler, if you want to add something, because DAPA preserved, the results are not yet published. Maybe you can throw some light on this role of DAPA Depletion in preserved ejection fraction.
Yeah, so, just to build on what Dr. Naushad just said, because you have these multi-organ system benefit, both at an organ level, so, you have left ventricular hypertrophy reversal, left ventricular remodeling reversal, improvement in ejection fraction, diastolic function, fibrosis, atrial remodeling. But then you also have these, vascular endothelial function, but systemic issues like inflammation and oxidative stress. It starts making sense why the same drug will prevent heart failure and treat heart failure with reduced and preserved ejection fraction. Unlike you have therapies like ACE inhibitors and beta blockers and MRA, they are all neurohormonal modulators. But neurohormonal activation is seen largely only in HFrEF. You don't have much activation in Hefpef, so those drugs tend to work only in HFrEF, not in Hefpef. Whereas the mechanism of action for SGLT2 inhibitor is such that it tends to work across the spectrum of EF.
Thank you, sir. Now, for the next panel discussion, I would like to invite Dr. Nirav Kumar. Take two questions for him. Share my screen. Yes. So, Dr. Nirav Kumar, there are a few questions which we got from the audience. So, when to start SGLT2 inhibitor in heart failure patient, and at what stage of heart failure? And what is the future of SGLT2 inhibitor in cardiovascular space, looking towards the newer happenings and then guidelines on SGLT2 inhibitor usage. And maybe you can comment on the DAPANORM trial, which I think Dr. Javed has already commented. So these are few questions which we got from the audience from India. So over to you, sir. Nirav Kumar.
Yeah, I think when to start SGLT2 inhibitor in heart failure, the guideline is not very clear. But this is only molecule which can be started, whether hypotension is there, whether hyperkalemia is there, whether renal dysfunction is there, whether patient is diabetic or non-diabetic. So I would like to start is as early as possible, because it is most tolerated medicine and it improves the outcome also. There is no doubt that it decreases the hospitalization also. And definitely it has got a great future, particularly the things regarding the heart failure with preserved ejection fraction with dapagliflozin. Things are not clear, but empagliflozin there is definite benefit in even in preserved ejection fraction also. So Dr. Javed can throw some light on preserved ejection fraction also.
Yeah. So, I mean, one thing is the field has a lot of debate whether we should just divide heart failure into two, preserve and reduce, and not three, and just call all the mildly reduced ejection fraction as just reduced and just divide it at 50%. So that debate aside, we obviously don't know the result of DELIVER trial, but I will be shocked if they show anything substantially different or less positive than what we already saw with Emperor Preserve. Just a couple of things to highlight on DELIVER, which is different than Emperor Preserve, from which we will get a lot more learning. One is in DELIVER, they are including patients with heart failure and recovered EF. So if your EF was 30% at one time, but now it's 50%, they are still included, whereas in Emperor Preserved, those patients were excluded. So that's a whole new learning. And two, Emperor Preserved only included patients who were not hospitalized and who were stable, whereas this is a little bit of a sicker population. So it will help us expand the entire spectrum of HFpEF, but we will eagerly await the results and see what we see.
Dr. Javed, I don't think that it has got class effect, because all the molecule in SGLT2 inhibitor in different group act differently, because dapagliflozin has no effect, no good effect in CAD patient, but in heart failure there is effect, but empagliflozin is CAD and heart failure in both. In canagliflozin it is so different. I don't think it is class effect. So definitely we are eagerly waiting for DELIVER trial.
Maybe one more question from my side to Dr. Javed Butler. Sir, there are a lot of things which are happening with SGLT2 inhibitor. Maybe can you throw some light on upcoming trials for different indications which are ongoing, and then maybe we will get some good indication expansion with SGLT2 inhibitor.
Yeah, so let me, yeah, I mean, the indication we are like, so we now already have heart failure with reduced and preserved ejection fraction with or without diabetes, CKD with or without diabetes, CKD without significant albuminuria. Those data are going to be coming out pretty soon. And then more data on acute heart failure, and then more data on post-MI patients. So these drugs are literally becoming the new age of ACE inhibitor and statin, that if you have cardiovascular disease, you really need these drugs. I think we'll get there in about the next 2 to 3 years. But Dr. Braunwald already wrote sort of this whole editorial saying that SGLT2 inhibitors are new statins, and literally the data are going in that
Thank you, sir. So our next panelist, because of some emergency, I think Dr. Lodha is not there. But then what we can do, we can take questions of Dr. Lodha. these are the two questions which we thought to put for Dr. Shailesh Lodha. What is the best place of SGLT2 inhibitor in the treatment of type 2 diabetes, and in which patient we should avoid usage of SGLT2 inhibitor? Is there is any definite contraindication where we should avoid SGLT2 inhibitor, or rather, to addition to that, in avoidance also the precautions that what we should take while putting the patients on SGLT2 inhibitor. So that is the second part, and then first part is what is the best place when to start in the management of type 2 diabetes. Maybe Dr. Siddiqui or Dr. Butler can throw some light on these two questions.
Am I audible?
Yes, sir.
So the best place is, I think, to begin along with metformin to most of the patients. Along with metformin, the first line of treatment should be metformin along with SGLT2 inhibitors. As far as its effect on neuropathy, nephropathy, I don't have any answer. Does it have any, I would like to know from Dr. Javed Butler, does it have any beneficial or harmful effect on diabetic retinopathy? And its benefit or harmful effects on neuropathy, because nerve conduction is regulated by sodium and you are decreasing the level of sodium. Suppose the patient with diabetes have diabetes insipidus also. Suppose the patient has Cushing's disease and other disorders which are associated with diabetes mellitus and heart failure. So you are on one side decreasing the blood sugar level. Along with that, those who are not diabetic or not hypertensive, you are reducing the level of sodium also in these patients. So my thinking is that we should take a precaution, see the patient, see the profile of electrolytes and other factors, and then we should assess how we should proceed. Because in our country, India, I can assure you, every physician has started writing SGLT2 inhibitors, maybe with metformin, or metformin is next to SGLT2 nowadays. So I would also like to ask Dr. Butler that where should we place it and what its beneficial or harmful effects on neuropathy, retinopathy, gastropathy, because SGLT2 channels are also present in the intestine. As far as treatment concerned, we generally start in our country at the first line of life.
Yeah. So lots of points to contend with. So first, remember that the SGLT2 inhibitors by sodium hydrogen exchange blockade reduces the reabsorption of sodium in the kidney. So they do not lead to excess sodium loss or hyponatremia, because, and this is the same thing they do with glucose, and that's why the risk of hypoglycemia is incredibly low with these agents and occur primarily if you're taking secretagogues or insulin. But if you're taking sulfonylurea or insulin, that's a different story. But if you're on DPP4, you're not going to get hypoglycemic with these agents, because your blood glucose have to be high enough to get into the kidney so that the reabsorption is blocked. So same thing with sodium. So these drugs are not associated with development of hyponatremia. What these drugs do that if you are sodium overloaded, then it decreases the sodium reabsorption overall. So to my knowledge, there are no concerns there related to sodium reabsorption. It's the excess which is lost. Then comes the issue of gastroparesis or the gastric effects. So to my knowledge, gastric effects are mostly related to SGLT1 receptor, not SGLT2 receptor. And that is actually the promise of drugs like sotagliflozin, because they are both SGLT1, SGLT2 blockers, but we don't have the study. The whole idea was that you will have both the fluid losses in the GI tract and in the kidney, and that they will be more powerful, but we don't know that for a fact right now. So you mentioned gastroparesis, GI neuropathy, and
retinopathy.
Retinopathy, yeah. So that issue came up with GLP-1 receptor agonists, some of those studies, because they lead to pretty rapid reduction in glucose. But again, you don't see the wide swings with an SGLT2 inhibitor. And therefore, again, there has been no published data of retinopathy risk that we saw in one study with semaglutide with GLP-1 receptor agonist, but not with SGLT2. And that is considered because of the rapid decline in glucose levels. But again, remember here, you don't see those rapid swings because all you're doing is the excess glucose filtered in the kidney is being excreted, and you don't get the hypoglycemia. And then the contraindication, so of course, type 1 diabetes is considered a contraindication. Now, many of the very sophisticated endocrinologists would not necessarily consider it an absolute contraindication, but at least for cardiology community, that's, I think, a fair thing. So absolute contraindication are previous hypersensitivity reaction, end-stage kidney disease, and a person is already on dialysis, type 1 diabetes. I would also be concerned with a lean type 2 diabetes with hyperglycemia and the concern that they are moving towards a type 1 physiology. So that's something to be concerned about. And then if somebody's in the hospital, is diarrhea, vomiting, or NPO, and their insulin doses are being decreased if they're not eating, that's a little bit of a setup for ketoacidosis and would not start in that situation. But other than that, I cannot think of any other reasons.
Thank you, sir. We'll take few questions from audience. So there are a couple of questions already put in the chat box. So one question from Dr. Amin, he wanted to understand only SGLT2 inhibition is not sufficient. We need a combination therapy with other drugs for better glycemic control. And so what is your opinion?
100%, but again, I mean, this is glycemic. So again, I would yield to our endocrine experts on the call today. But remember that in hypertension, we had this whole sequencing, give one drug, we have two drugs. And now the guidelines are pretty clear that if your blood pressure is up between 1 to 20 mmHg, start one drug. But if it's more than 20 mmHg, just go ahead and start the combination therapy. With one drug, you're not going to go there. With heart failure, with MI, we start combination therapy anyways because of the outcomes benefit. And I think the diabetes is the same, that I think the combination therapies are needed to improve outcome. Remember, it's not only glycemic control, but it's improving outcomes. There is at least one trial going on, starting with a combination of SGLT2 and GLP-1 receptor agonists. We'll see what the results are. But what Dr. Hamdani is saying, that combination therapy is needed, to me makes a lot of sense. Now, if somebody's hemoglobin is 7.1, that's a different story, but you're not going to get those patients, right? Most patients will have hemoglobin A1C or whatever, 8.5 or something like that, and that combination therapy makes a lot of sense.
Thank you, sir. One more question. Is there any role of DAPA in treating PCOD?
We need to talk to some nephrologists. I have no idea.
Right.
Well, this is not, I was thinking about polycystic kidney disease. This is actually polycystic ovarian disease. So maybe some endocrinologists can comment on this. I have no idea.
These are a few questions that we got, and I think we concluded on time, and it's time to give vote of thanks. So thank you very much. First of all, I would like to thank Dr. Javed Butler for giving us such a wonderful and clear thoughts about SGLT2 inhibitor, what to start, when to start, and what are the precautions we should take, and definitely the futures, which are the future trial which are ongoing, and then we can see SGLT2 inhibitor is another statin, in terms of indication that we are expecting. So thank you very much for that. Also, I would like to extend my thanks to Dr. Siddiqui for moderating the session, and Dr. Naushad and Dr. Nirav Kumar for panel discussion. So basically, sir, this program is brought to you by Alkem Laboratories Mumbai, and then Alkem, we have a metabolic division. So they really everyone, and and good night and be safe. Thanks. Thank you.